Let me introduce Hayley. Vicky Shim, the organizer, and I have known Hayley when she was doing her PhD in ABI 10 years ago, not long ago, studying melanoma cancer. She then completed her first postdoc research in ABI on studying breast cancer, and then a second postdoc in Melbourne studying prostate cancer. The highlights are the receipt of a Young Investigator Grant 2014 and a Project Grant 2017 in Australia. She then won from the HRC New Zealand a Sir Charles Hurkett Health Research Fellowship 2020. Bringing her talent and her technique back to New Zealand, she is now leading a new cancer imaging research group in ABI with a research program on advancing bioengineering tools to enable precision treatments of cancer. Hayley?
Okay, thank you very much for the introduction, JC. And hi to everybody who's listening. Thank you for turning up for my talk. This is the first time I've actually done a talk at the ABI since returning from Australia. So it's quite nice to be able to explain a bit about the research that I'm doing. So I'll just start off with a bit of background. So JC's actually explained a lot of this already, but I'll just quickly go through it. So I did my engineering degree and my PhD at the University of Auckland. I actually majored in engineering science at the time I did my engineering degree because bioengineering wasn't available as a major. The thesis that I did was looking at patterns of metastasis in patients with melanoma, so looking at patterns of lymphatic drainage essentially, which is one of the roots for cancer metastasis. And you can see an image there of myself sitting on level 6 of the ABI. There's different people sitting there now, and it looks a little bit, yeah, it's changed a little, but yeah, it's nice to be back home. So after I did my PhD, I carried out my first postdoc in the biomechanics for breast imaging group, so with Martin Nash, Paul Nielsen, and Vijay Rajagopal, who some of you will know. So that postdoc was really focused on trying to do a clinical validation study of mapping breast cancer between X-ray mammograms and MRI using the group's framework. And I was also able to initiate a new field of research within the group, which was looking at analysing patterns of breast cancer spread through the lymphatics. So as we've already mentioned, I then decided to cross the ditch to Australia and did my second postdoc. So I really wanted to expand my expertise in cancer research, and I really wanted to get a job at Peter Mac. Unfortunately, I did. So Peter Mac is it's a public hospital, and the only public hospital in Australia that's solely dedicated to cancer. So they treat cancer patients, but they also do a lot of research as well. So it was a great place to go, and they've actually they're a Department of Oncology of the University of Melbourne. So there's a direct link there to the university. So during my time there, I worked on developing novel approaches to prostate cancer radiotherapy, and I also did a small project looking at MRI biomarkers for kidney cancer for patients who were undergoing radiotherapy. So that was part of a clinical trial. So after spending about 7 years in Australia, I decided to move back home to Auckland. Fortunately, my Australian husband and our 2 young kids were happy to come as well. So yeah, we flew over and moved back in March of 2019. I spent a little bit of time just on mat leave before being fortunate enough to receive a fellowship from the HRC. So this is a 4-year Sir Charles Hurkett Health Research Fellowship. So that's currently what where I'm getting my support from at the moment. And my goal at the ABI is really to establish a new cancer imaging research group, building on the research that I've done previously. And that's all towards developing precision cancer tools. So this ties in with my overarching mission for my career to date, which is to apply bioengineering methods to provide patients with the best in cancer treatment. So this all leads into the field precision oncology. I'm sure most of you have heard of precision medicine. So this really is aiming to provide patients with the best in cancer treatment by tailoring it to the individual patient's cancer. So that can include a range of different things, one of which is tumour heterogeneity, which is an important factor to take into account when planning treatment, as well as the genetic profile of the patient's cancer. You can see a diagram here on the bottom right that shows different aspects that are important to take into consideration when planning treatment, and medical imaging is one of those. So what I'm really focusing on is medical imaging research for this cancer group. So there's been a number of technical advances recently that have occurred in radiomics, in big data, machine learning and AI that really are driving rapid growth in developing precision oncology tools. So a lot of these tools they're useful for things like screening for cancer, for diagnosis, staging, stratifying patients for different types of treatment, as well as looking at outcomes of different treatments that patients have. So this image here is just showing just a nice schematic of the different forms of imaging that a patient may undergo when they're having cancer treatment planned and delivered and followed up, etc. So we have this anatomical imaging. There's also functional imaging where you can look at the physiology of a patient's cancer, but there's also molecular imaging as well, which looks at cancer metabolism and a range of different components of a patient's cancer. So in terms of what I'm looking at for my fellowship, I have 3 specific aims. So these aims are working towards developing precision cancer tools for 3 types of cancer. So the first aim is to look at melanoma. So we want to develop predictive software tools that can indicate potential patterns of spread via the lymphatics. So this will give patients as well as clinicians a decision support system so they can plan the best treatment. The second aim is to develop predictive software tools for breast cancer. So this is very similar to aim 1. Again, we're looking at patterns of spread through the lymphatics and developing decision support systems. The third aim is to build upon the research that I did at Peter Mac. So that is developing quantitative imaging biomarkers for patients with prostate cancer. So the goal really is to develop imaging biomarkers that can indicate whether a patient has responded positively to radiotherapy. And if they haven't, then various interventions can be given so that treatment can be tailored to the individual patient and how they have responded, and give the patient the best chance of cure, really. Okay, so looking at aim 1, so this is developing the predictive software for melanoma. Most people in New Zealand will know what melanoma is. It's the most aggressive form of skin cancer, and unfortunately we have the world's highest incidence rate here. And for patients, the most important thing that they need to determine is whether their melanoma has spread to the lymph nodes. So the lymph nodes that directly drain the primary tumour site are called sentinel lymph nodes. And if cancer has spread beyond the skin, it is considered stage 3, and it's much more difficult to treat. So I've just got an image here showing the lymphatic system because it's, I guess, not very well known. A lot of people will know in detail the blood circulation system, and I often think that the lymphatics are kind of like a second cousin that nobody really pays much attention to. But the lymphatics are a network of vessels in the body. There's lymph nodes in various regions as well, and extra fluid that is within tissues after the blood vessels have delivered nutrients to tissues is taken back up through the lymphatics. Okay, so in terms of looking at cancer metastasis that could occur via the lymphatics, the exact anatomical location of these sentinel lymph nodes in each patient, it can be determined using what's called lymphoscintigraphy imaging, as well as SPECT-CT imaging. So these are nuclear medicine scans, where a patient is injected at the site of their primary melanoma with a radioactive tracer, and then that tracer is taken up into lymphatic vessels and drains into sentinel lymph nodes. So on the left here you can see some lymphoscintigraphy images where here's the injection site here, and you can see some vessels showing the tracer has moved through the lymphatics and highlighted various sentinel lymph nodes. On the right here we have a volume rendered SPECT/CT image. This is actually the same patient as the one on the left. The melanoma site's here on the chest, and then there are 3 sentinel lymph nodes between the ribs. So each of these sentinel lymph nodes are then removed and tested for metastasis. So here's just a slide giving a bit of an overview of some of the work I did during my PhD, since this fellowship is actually building upon this work. So what I did just over 10 years ago now was I used a large lymphoscintigraphy imaging database from Sydney. It was actually the world's largest database of over 5,000 patients. And I matched this data from 2D images onto a 3D anatomical model. So here's my nice finite element model that I created using CMGUI software developed at the ABI. And I was also able to use the visible human data set to develop a lymph node model as well. So there are 43 different node field locations where sentinel lymph nodes could be located. So all of this data, after it was mapped, allowed me to develop novel 3D visualization of the data. So here you can see a 3D heat map for this one on the left here is showing the likelihood of lymphatic drainage to the left axilla. So the axilla means the armpit. You have the usual color map, so blue is unlikely and red is 100% likelihood. So all of the primary melanoma sites that were located on the left arm had lymphatic drainage to the left armpit. And what's interesting here is that lymphatic drainage could occur from sites on the opposite side of the body to the left armpit. So prior to a lot of this lymphoscintigraphy imaging being done, most people assumed that lymphatic drainage of the skin never crossed the midline of the body, and it never crossed a sort of theoretical line around the belly button, the umbilicus. So this was all based on lines developed by a guy called Sappi, who was a Frenchman. He did a whole lot of cadaver studies back in 1874. Yeah, they were incorrect for a number of patients. So we were able to redefine Sappi's lines and present a much more quantitative display of lymphatic drainage patterns in patients. So this data also allowed me to look at differences in regions of the skin that drain to either one node field or more node fields. So this allowed me to look at whether a patient would have predictable versus unpredictable lymphatic drainage. And with these heat maps, on the left here, you can see a heat map showing the likelihood that any area of skin will drain to just one lymph node. So the legs and close to the armpit is red, which means it's highly likely that these regions of skin will only have one site of metastasis. Whereas if you look at patients who had 2 or more node fields, 3 or more node fields, or 4 or more node fields, you see highly unpredictable drainage in the posterior and anterior torso and the head and the neck regions. Sorry, it's been a while since I've described my PhD research, so please forgive me for fumbling over my words there. So here, this next slide is showing a predictive software tool that I developed. So I was able to present this information in an interactive form for clinicians, where the clinician or patient, they're able to select a region of skin on my skin model, and it will show all the likely sites that cancer may spread that they'll need to check. So here you can see a site close to the armpit, where there were 10 patients who had primary melanoma here, and all of them had lymphatic drainage to the left axilla. Then if we look at a region of skin close to the midline of the body, there were 21 patients who had melanoma there, and there's much more complex lymphatic drainage. Again, I was able to look at the head and the neck, and there was highly complex lymphatic drainage here, so it's very, very difficult to treat if cancer has metastasized from these regions of the skin. Okay, so with this predictive software, I was actually able to present this data in the form of websites, which is still available online at those URLs. And in terms of the fellowship that I'm working on now, the goal is to actually extend this software quite significantly. Firstly, we'll be able to add over 10,000 new patient imaging studies. So this will give us a total of just over 15,000 imaging studies, which will be, I think, the largest database in the world. That will give us superior statistical power with this software tool. We'll also be able to incorporate 3D SPECT/CT for the first time. We only had the 2D lymphoscintigraphy imaging for my PhD because they didn't have a SPECT/CT machine at the time. And another exciting extension to the work is that we're going to be linking the imaging data with a clinical follow-up database from the Melanoma Institute of Australia, which is the world's largest treatment and research facility for melanoma in the world. And they have, I think, a database that dates back to about the 1950s. So it's very extensive. They have epidemiological and pathology and follow-up data on these patients. So it will allow us to answer a lot more questions about patterns of lymphatic drainage. So the sorts of questions we'll be able to answer, which have been debated for quite a few years, include, do multiple draining node fields adversely affect prognosis? And are there differences between males and females? So there have been publications for both of these questions where viewpoints on each side have been presented. So it will be interesting to see what this data shows. So sorry, I also haven't mentioned, so Thurangadon, if you can see there, he's a research assistant who's working with me on this particular aspect of the project. Okay, so the clinical use of the software, so it's not going to replace imaging studies for individual patients, but it would be able to help guide treatment selection for particular patients. Specifically those who cannot have an imaging study for health reasons. One of the, I think, most exciting uses for it is that it can guide treatment follow-up. So patients who are coming back to clinic to be checked for nodal metastasis, they'll be able to use ultrasound and know which node fields to check. It could also be used to predict primary sites for cancers of unknown primary. So there's varying statistics on this, but 2 to 5% of patients will have cancer diagnosed without knowing for certain where it first originated. So this will be a particularly helpful tool for that. And it's also a valuable education resource as well. So moving on to aim 2 of my fellowship. So this is looking at predictive software for breast cancer. Breast cancer is the most commonly diagnosed cancer in both New Zealand and Australian women. And like melanoma, the metastatic status of the draining lymph nodes is the most important prognostic factor. So you can see an image here on the right that shows the lymphatic anatomy of the breast. So most people, if they know much about the lymphatics, they will expect that patients who have had breast cancer, they may need to have their axillary lymph nodes removed, so lymph nodes under the armpit, but they may not know that there are other lymph node fields as well that need to be checked. So this includes internal mammary lymph nodes, interpectoral lymph nodes, and lymph nodes above and below the clavicle. So it's important that clinicians check each of these sites for metastasis. So again, lymphoscintigraphy and SPECT-CT imaging can be used to precisely locate these sentinel lymph nodes in patients. And they have found that sentinel nodes are often located outside the axilla. Patients can have more than one, of course, so you could have a couple of sentinel nodes under the armpit and then, say, one in the internal mammary chain. So it's important that all of these sentinel nodes are located. And particularly with SPECT-CT imaging, which offers far superior anatomical localization of these sentinel lymph nodes, once that was introduced just over about 10 to 20 years ago, that has allowed quite a redefinition of the understanding of lymphatic anatomy of the breast. So drainage to the armpit is actually a lot more complex than it was first thought. So just going back to some prior research, so 2009 to 2011, I was fortunate to supervise a very good student, Evan Blumgart, who was able to map some 2D lymphoscintigraphy imaging data onto a computational model and analyze patterns of metastasis in breast cancer patients. So he loves statistics and was able to apply Bayesian techniques to look at patterns of lymphatic drainage and look at distribution of primary tumours as well. So this is a screenshot showing an interactive web-based tool that he developed, and it's still online now. So you can see here that we have just a few discrete locations for where these breast tumours are located. So there are only 9 locations according to the coding for this lymphoscintigraphy data. So a tumour could be either behind the nipple or in one of 8 regions around the breast. And then, as I've mentioned, we have 5 draining node fields. We've also got this interval node outside the anatomy. And an interval node is a sentinel lymph node that's in the body, but it's not in a predefined node field. So because there was no specific location for where it would be in all patients, we've represented it outside the patient. So again, similar to the melanoma tool, you can click on regions of the breast and look at patterns of drainage. So here, if a patient had a primary tumour in the upper outer breast region, 99% of the time it would drain directly to the axilla. And you can see that 19% of the time you would also have drainage to the internal mammary chain. Then if I click on a different region of the breast, you can see that the pattern of drainage changes. So you have only 94% of patients with drainage to the armpit, so that has reduced. And interestingly, you have about 61% of patients will have drainage to the internal mammary chain. So this is a significant jump. So I think, yeah, for clinicians in particular, it's very important that they check that internal mammary chain. So lastly, I've just got a screenshot here showing the range of tumour prevalences for patients in this database. So the majority of patients had their breast tumours in this region here, close to the axilla. Okay, so what we are going to be doing now is significantly extend this predictive software tool by adding thousands of new patient imaging studies. So this will bring the database to over 5,000 patients. What I'm particularly excited about is that we'll be able to incorporate this 3D SPECT-CT data into the modelling. So the goal is to actually develop a population-based atlas of breast sentinel lymph nodes. This will use image registration techniques to fuse the CT images, and then we'll be able to take the sentinel lymph node locations from the SPECT imaging. So down the bottom here, I just have 2 screenshots showing some previous work that's been done on other atlases. So here we have a sentinel lymph node atlas for prostate cancer, and there are various other atlases out there, particularly for radiotherapy treatment planning. So this one here at the bottom is looking at nodal recurrence in breast cancer patients, but this atlas was built using PET-CT. Okay, so just a summary of what the clinical utility will be of these predictive software tools. So very similar to the melanoma work, we will not replace the imaging studies for breast cancer patients, but it will be helpful for treatment selection and follow-up, and particularly with developing a comprehensive 3D atlas of breast and lymph nodes. This could be particularly helpful for planning radiotherapy treatment for patients who have nodal irradiation carried out perhaps after surgery, or other forms of treatment such as chemotherapy. Okay, so just an extra slide here. So I am also quite excited that I've recently been able to establish a collaboration with Associate Professor Harusuami. So he's a world expert in lymphatic anatomy. He's conducted a number of anatomical and imaging studies of the lymphatics, and he is keen to work with us to develop computational models of the lymphatics in breast cancer patients. So he is working at the Australian Lymphedema Education, Research and Treatment Centre. That's a very long name there, but yeah, his focus right now is imaging patients with lymphedema, which is an aberration to the lymphatics, often caused by treatment or cancer treatment. So we'll have access to a wealth of imaging data through that collaboration. All right, so moving on to aim 3 of my fellowships. So this is looking at developing imaging biomarkers for prostate cancer, and ties in with the work that I did in Australia at Peter Mac. I know there's, as far as I'm aware anyway, I don't think there's any research at the ABI into men's health. So it's exciting to be starting to do some research there. Okay, so prostate cancer, as most of you will know, is the most commonly diagnosed cancer in both New Zealand and Australian men. A number of new cases and deaths per year, unfortunately. So the prostate itself is a gland that's located directly underneath the bladder in patients. So it's about the size of a walnut, and the urethra runs directly through it. So in terms of treatment for prostate cancer patients, so radiotherapy is a very effective form of treatment. And at the moment, the standard of care for patients is that they receive a uniform dose of radiation to the prostate, regardless of where their tumour is located in the gland. So here you can see various treatment plans for patients. So at the top, you have external beam radiotherapy, where radiation beams are shot through the patient to the target, which is the prostate. At the bottom, you have a couple of plans for what's called brachytherapy treatment. So where radioactive seeds or sources are inserted into the prostate. And the colour wash there is showing the dose distribution to the prostate. So there is an alternate approach to delivering radiotherapy to patients though. So focal radiotherapy is an approach where instead of giving a uniform dose of radiation to the prostate, a non-uniform dose distribution is delivered, and the aim of this is to actually target the tumour location more precisely. And the goal, of course, is to reduce treatment-related side effects, so including impotence and incontinence, which, of course, we would like to reduce. So here you can see 3 different proposals for focal therapy. Groups around the world are delivering focal therapy at the moment. So one of the methods that's used is ultrafocal therapy. So this is where the prostate tumour is ablated. So the radiation is targeted just at the tumour and the rest of the prostate is left alone. There's focal therapy here where just half of the prostate is irradiated, and that's based on where the tumour is, and the other half of the prostate is left alone. The third option is focus therapy. So that's where the tumour is given a higher dose of radiation and the rest of the prostate is still given radiation, but at a lower dose to account for multifocal disease. Okay, so also at the moment, treatment planning for patients is often, or most often, carried out using CT imaging alone. However, there is a lot of research towards using MRI instead of CT, or as well as CT. So using MRI instead of CT offers a lot of benefits, one of which is the improved soft tissue contrast. So you can see in these images at the bottom here, the prostate on the CT images, it's very difficult to actually define where the anatomical boundaries of the prostate are, whereas on MRI it's a lot more apparent where these boundaries are. So radiotherapy can be targeted and planned much more easily using MRI. So particularly using multiparametric MRI, we're able to both localize the disease as well as characterize the disease. So this is particularly helpful for radiotherapy, where we're wanting to ensure that we're giving the right dose to parts of the prostate that may have more aggressive disease or areas of hypoxia, etc. Okay, so this next slide is really summarizing the whole goal of what I was working on at Peter Mac. So in light of issues that currently exist with carrying out uniform dose distributions on patients, as well as issues using CT for planning, our group was working towards implementing what's called biofocused radiotherapy, so BERT for short. So the goal of this is to deliver a personalized and non-uniform dose distribution to patients, which has been planned using imaging data, both tumor location as well as characteristics that we're interested in, so the tumor biology. So this is taken from MRI imaging as well as PET where it's available. So this is quite a paradigm shift compared with a lot of other research that's happening, which is really just looking at where a patient's tumor is located. We're not interested just in the location, but we're interested in the biology of the tumor, biology that's important for optimizing radiotherapy treatment response, such as I said, cell density, tumor aggressiveness, and hypoxia. So if you look at this flow chart here, how this BERT treatment planning would work is we would have a new patient coming into the clinic. After they're diagnosed with prostate cancer, we would acquire patient data, so quantitative imaging, multiparametric MRI, and PET. That would all be fed into treatment planning software that would allow us to optimally plan treatment for that patient and deliver biofocused radiotherapy using either external beam approaches or brachytherapy. After treatment, the patient would then undergo a series of imaging studies at various time points, and then we would assess the patient outcome. So this project is, there's a large team involved, as you would expect. So when I moved to Peter Mac, I was working with Annette Howarth, and I'm continuing to work with her now. So this is her here. She's the overall project lead for this BERT project. And we have co-supervised a number of PhD, masters and postdocs together, some of which are here. Oh, sorry, went too far. Yeah, so I'm still working very closely with Annette and the team. She actually moved to Sydney a few years ago, so even though we're at Peter Mac to start with, she's now based at the University of Sydney, and we have an NHMRC grant together. So I think we've got a couple more years of that grant to run, hoping to get more grants, of course. Okay, so this next slide is really a summary of what I was doing during my postdoc at Peter Mac. How am I going with time? I think I'm all right, sorry. Tell me if I need to speed up, JC. Okay, so in terms of planning BERT treatment, the way we are intending to do it is to use predictive models so that we can extract the important information that we need. So we need to define the patient's tumor location within the prostate and the tumor characteristics that are important for informing treatment planning. However, the challenge for this is to, how do we actually know what we are seeing on multiparametric MRI and PET? we need a high level of detail and knowledge of what we're seeing in the imaging data. So the focus of really the 7 years that I was at Peter Mac was to solve this problem. So I was involved in a study where we recruited 70 patients who had prostate cancer, and they were having prostatectomy to treat their disease. So that's where the prostate is removed, surgically removed. And we carried out multi-parametric MR on them before they had surgery. And then we did an ex vivo MRI of the prostate specimen the day after the prostate was removed. And then we acquired the pathology data as well. So my role was to oversee this project, acquire the imaging data, and then develop methods to co-register the data together so that we could use it as training data for our models to implement biofocused radiotherapy. So I've got a few slides here showing the data that we acquired. So what really set this work apart was that we were able to do the ex vivo MR imaging of the prostate specimen after surgery. It was much easier for us to do this because I was working in a cancer hospital. So the day after surgery, we were able to take the prostate specimen, we put it in a sectioning box that we custom designed. We did our MR imaging, and then we sectioned the prostate into 5mm sections using our sectioning box, and did the routine clinical reporting on the H&E stained histology. So it was very important for us that we had high resolution ground truth data. So for each of the H&E stained slides, we scanned them at high magnification to get very high resolution data. And part of the work that I did was to develop image processing and machine learning methods to look at the characteristics in the prostate that we were interested in. So here you can see a computed cell density map. And we worked with researchers in Vienna to implement machine learning methods to predict high and low grade tumour. So with all of this imaging data that we had, the challenge was to actually co-register the imaging sets together. So we had our in vivo imaging here on the left. We had our clinical data, a suite of scans. What I was able to do was co-register the in vivo MR data with pathology by using the ex vivo MRI as an intermediate registration step. So of course you would expect that once the prostate is removed from a patient, there are all sorts of deformations that take place. There's shrinkage of the prostate due to loss of organs around the organ. There's loss of vascularization as well. So we applied deformable image registration to align these images with each other. And then we were able to co-register the histology data directly with ex vivo MR because we had such a customized image acquisition process. So here's a screenshot showing an example patient where we had the histology data and we could overlay that with the in vivo MR. We're also able to look at correlating some of these tumor characteristics. So for example, we have cell density here overlaid with an ADC map from diffusion weighted imaging. And all of this data, we have been able to combine it together. So here you've got all the data we acquired on the left with the co-registration framework. Once the images were in the same spatial frame of reference, we could input that into machine learning models to develop predictive models of what we were interested in, which is on the next slide here. So we have been particularly interested in being able to predict tumour location as well as tumour characteristics. So Dr. Yusun here, he was a PhD student that I was fortunate to supervise at Peter Mac. He developed methods to analyse this data and predict each of these characteristics we were interested in. And after developing these models, the goal is to use these predicted maps as input to radiotherapy treatment planning. So during Yusun's work, he implemented a number of radiomics and radiogenomics methods to essentially extract features from the imaging data. So radiomics is it's an emerging technology for discovering imaging biomarkers that can allow us to look at tumour phenotype and tumour heterogeneity as well, which is particularly important for informing personalised cancer treatment. So in this image you can see from the multi-parametric MRI, we're able to extract a range of features, I mean thousands of features, by carrying out an analysis of this data either on a region of interest approach or by using a voxel-wise approach. We can then correlate the information with various aspects of biology. So either looking at an individual patient through to the genetic level. Okay, so in terms of the work that I'm focusing on at the ABI, so we have this very comprehensive data set of 70 patients, but there are still a lot of questions that we want to answer and a lot of analysis that still I think is important to carry out so that we can understand what or how ground truth histology correlates with MRI and what sort of imaging biomarkers may be relevant for predicting treatment response, quantifying tumour heterogeneity, etc. So I'll just go through a couple of projects that I'm currently working on. I might have to speed through it, I think. So sorry, I'll just speed through this. So one thing we're looking at is how valuable is DCE MRI for treatment planning and for assessing the risk of prostate cancer. So DCE MRI allows radiologists and clinicians to assess the perfusion in the prostate, which is increased in tumours. However, there's currently safety concerns about the contrast agents that are used because they can stay in the brain for longer than we want. So there are radiologists around the world who are not always using DCE MRI, but they are reporting they're doing their PIRAD scoring by using biparametric MRI, so that's just T2 weighted and diffusion weighted imaging, so excluding DCE. So I'm particularly interested to find out what it is about DCE MRI that is the most valuable and what extra information it is adding that is not possible to get through other MR sequences. So this work is actually we've been collaborating with a company in London called Image Analysis Group. So this is a company who developed software actually for rheumatoid arthritis, but they have very nice methods for analysing DCE MRI data in particular. So using the software, I'm able to compute a number of parametric and quantitative maps from DCE data, and I'll be correlating that with ground truth histology data. Hoping to publish something by the end of this year for that. Okay, so another question that we're interested in looking at is what is the role of PSMA PET, particularly for planning radiotherapy treatment using this biofocused approach. So PET imaging is a molecular imaging technique, and for prostate cancer patients, PSMA, which stands for prostate specific membrane antigen, that's a particular tracer that's injected into patients during imaging that can detect very small tumours within the prostate. So prostate cancer overexpresses PSMA, and the benefit of PET imaging over MRI is that it can detect very small lesions that multiparametric MRI may miss. So in this image here, you can see a lesion that is picked up by PET-CT that's not highlighted in the multiparametric MR data. So there are still a range of questions that exist for Now, what information can we see in PET that we can also see in multiparametric MRI? What are the sensitivity and specificity values? And to date, I've been able to do a pilot study analysing the correlation between MRI and PET. We've been able to show that there are negative correlations between some bold imaging and Psma PET, and also with DCE MRI data. But further validation is required for this. And to date, I haven't applied any radiomics analysis to this data, but it's a very rich data set, and we have a number of clinically relevant questions that we would like to answer. So the final aspect of the fellowship work I'm carrying out is to actually look at developing imaging biomarkers for prostate cancer patients to look at treatment response to radiotherapy. So for this, we'll be doing a sequential imaging study on patients being treated at Auckland City Hospital. And the idea is to both see whether we can validate existing biomarkers, but also identify new biomarkers that may indicate treatment response. So at the moment for prostate cancer patients, after a patient is treated with radiotherapy, they're generally followed up using blood tests. So prostate-specific antigen, PSA, is usually what is assessed to determine whether a patient has responded and been cured. Once the PSA level drops to 0 and stays at close to 0, they're effectively cured. However, once, if PSA starts to rise again, then cancer will have or may have recurred. So there's thresholds for determining if cancer has recurred. But the issue with PSA is that it lacks sensitivity and specificity. So you cannot be certain whether a patient has local recurrence or distant recurrence. So we're hoping to improve that by developing quantitative imaging biomarkers to much more effectively assess treatment response. Oh, sorry. So yeah, the goal is to recruit patients at Auckland City Hospital who are having standard radiotherapy, and then we'll be carrying out multiparametric MRI imaging at Mri at 3 different time points, so both before treatment and then 6 months and 12 months after radiotherapy. And then we'll look at changes in multiparametric MRI images between the scans and also against various blood-based measures, including PSA. So this will really be a pilot study, and it will inform larger trials that we intend to run in the future. This is the data from this will be pulled with a larger study happening in Sydney with the collaborators that I have there. So I just had a few extra slides at the end here covering some of the work I did looking at imaging biomarkers for kidney cancer at Peter Mac. So I might just go through this quickly. So I was fortunate to be part of a clinical trial at Peter Mac where they were looking at the technical efficacy of carrying out what's called SABR treatment for patients with kidney cancer. So SABR is stereotactic ablative body radiotherapy. So this is where they deliver high doses of radiation to patients' tumours, which allows them to give fewer treatments to patients, so they can give a higher dose at once or over a few fractions, as opposed to smaller doses of radiotherapy over a number of weeks. So the question here was, we were wondering whether MRI could much more adequately assess treatment response, particularly in comparison to the current criteria that's being used, which is called RECIST. So RECIST is, can be determined using CT or MRI, but what it's looking at is really just the morphological change in a tumour. So if a patient has responded favourably, it's really only being based on whether the tumour has shrunk or not. But the problem is with kidney cancer, even if a patient has responded favourably, there will still be residual tumour left after treatment in a lot of patients. So it's not always the best biomarker of response. So what we did was patients had MRI carried out at 14 days after their SABRE treatment was delivered, and then also 70 days after treatment. They had the standard follow-up CT carried out as well at various time points. And what I was able to do was look at the changes in parameters in the MRI data at these early follow-up scans and correlate those changes with tumour volume changes as shown on the CT, which was the standard indicator of treatment response. So what I found was that changes in the MRI data, particularly in contrast enhanced imaging. So, okay, 5 minutes left. Thanks, JC. Yeah, so changes seen in the MRI data, specifically the diffusion weighted and DCE contrast enhanced imaging at 70 days post-treatment did significantly correlate with the amount of tumour shrinkage or the amount of tumour growth that was shown on follow-up CT at 12 months after treatment. So you could see very early on in the MRI whether a patient will be responding favourably to treatment or not. Oh, I don't know what's happened there. I can't change my, oh, there we go. Yeah, so this is just a quick screenshot showing some of the MRI biomarkers that I was able to identify from the contrast enhanced imaging. So I was able to show that there was a very high correlation between some of these parametric maps from DCE with tumour shrinkage. And this work motivated another study to be done in the second clinical trial. So there's a second clinical trial currently underway at Peter Mac as well as other sites in Australia. I think there's one overseas, and they will be obtaining multi-parametric MRI data to further quantify these biomarkers. Okay, so just a summary, since I know I don't have much time left, but I've covered a lot of material, I think. But yeah, so the goal really for this new cancer imaging group that I'm aiming to set up is to develop precision cancer treatment tools. This includes predictive software tools for melanoma and breast cancer, as well as imaging biomarkers for prostate cancer patients, specifically patients who are undergoing radiotherapy treatment for their disease. And I guess my overall aim really is to use these tools that we're developing to and apply them to other solid tumours in the future. So I just wanted to quickly put a plug in here. So at the moment I have a couple of master's and PhD projects that are available, so specifically for the breast cancer and prostate cancer work. So if you're interested yourself, or if you know anyone who is interested, then please send me an email. And lastly, I just have a series of acknowledgements there for collaborators that I've been working with. Okay, thank you very much.
Thank you, Hayley. Impressive work. I can tell because you published in Lancet Oncology, Impact Factor 35.
Thanks, JC.
I now invite participants to either post the question in the chat room or use the reaction thumbs up button to signal that you have questions and wait until Hayley picks you, I guess. There are questions in the chat room already, Hayley.
Yeah, okay. So I can see the first one from Martin. He's asking, will you be looking into multi-factor mixed effects regression techniques to see if combinations of the rich variety of non-invasive imaging signals can provide more specific prediction of prostate cancer? Yes, I mean, there's quite a lot of research that is happening using this imaging data that I didn't go into in this talk. So I guess the answer is yes, we have a number of statistical methods being applied to analyze and mine this data as much as possible. yeah, I probably will stop there. Otherwise, yeah, there's a lot more detail if we go into. But I think, yeah, in particular, I mean, this data set is particularly rich, and I would really love to analyze it as much as we can to get as much out of it. So secondly, Bill Wilson has asked, do you have any interest in oxygen-enhanced MRI for assessing hypoxia in the prostate, or acido-assessed MRI, which assesses extracellular pH but may map the same hypoxic regions? This would connect well with work on hypoxia-targeted agents in Auckland. Yeah, I would be particularly interested in that. I think while I was at Peter Mac, one of the most difficult things for us was imaging hypoxia. Not just the imaging, but also how do we validate hypoxia? You may, sorry. No, I thought someone was speaking. Yeah, so I guess the issue when you remove the prostate from the patient and then do your you know, ex vivo MR, and then you do your histology and you're sectioning the prostate, if you stain for hypoxia, the tissue has already changed significantly, and the areas that were hypoxic in the patient are not necessarily going to align with what you see in the formalin fixed tissue. So anything that we can do to improve our analysis of hypoxia, we'd be very interested in looking further into. Okay, so Richard Clark has asked, I have heard that there is quite a lot of biological variability between the lymphatic system of different individuals, perhaps more so than in the CEV system, cardiovascular system. Is this something you have seen in your work? Yes, thanks for the question, Richard. So I think the point of developing these I guess atlases of lymphatic drainage are to present the variability in patients. So if everyone had the same lymphatic drainage pathways, we wouldn't need to do this lymphoscintigraphy imaging or SPECT-CT. But of course there is a huge amount of variability, so yeah, imaging needs to be done. Something that we will be able to look into further with this work is how the lymphatic system alters in patients who have had trauma to the lymphatics. So that's work that I'll be wanting to do with Huru Suami, who I was mentioning earlier. He's worked for over 20 years on the lymphatic system and has done imaging as well as anatomical studies. So there are definite, I guess, similarities between patients in terms of how the lymphatics drain, but you can't assume that I guess you can't assume that you can always predict accurately in individual patients. I hope that answers your question. So Thor asked, I had a similar question to Martin. There are methods now where you can train AI methods to use structured text in combination with histology and imaging data for personalized medicine. Christopher Ray at Stanford has been doing some of this work and has a nice library on GitHub. Okay, I'll have a look into that.
Maybe not.
Yeah,
maybe not a question, Hayley, more of a comment.
No.
I guess it's along the same lines of what Martin was going. You know, you've got all this other data potentially that you could use to train your model, and it's you know, initially I was thinking there's lots of doctor's notes, histology information that gets you know, dealt with by all of the different experts, I guess, the medical experts, and all of that information could potentially go into your models, right, for prediction.
Yeah, yeah. I mean, we are including information in clinical reporting. I guess I didn't really cover it in this talk, but yeah, I guess things like Gleason's score and as much information as we can gain from the clinical reporting, we will be using in the predictive models.
Cool, thank you. Great talk.
Oh, thanks. Yeah, some very good questions there.
Mm-hmm. Anyone has questions? Interesting that I cannot see who is typing.
It's me, it's Dick Bellamy. If you're referring to the one that asked about, have you got any ideas about looking for predictive genetic markers that might correlate with your outcome models? Because of course, if you're a clinician, you want to choose the mode of treatment before it initiates, rather than analysing at the end of it whether or not it has worked, if that's at all possible. So it's not my field, but where are we at with some sequencing is so straightforward these days, getting those, looking for those sorts of correlations?
I guess it's a difficult question for me to answer. I feel a little bit out of my depth since I'm not a clinician myself. I mean, I know there's a lot of research happening around the world, and particularly at Peter Mac focused on prostate cancer. I guess I would need to defer to one of my colleagues who's not here, unfortunately, on that question. Yeah, it would be much nicer to have, I guess, the optimal treatment known ahead of time as opposed to trying to determine that after the treatment's being delivered. Yeah.
Yeah, well, I guess the question is, if you just got onto PubMed and put in prostate cancer genomic markers, question mark, there's probably relatively vast literature there. But I guess my question is really targeted at what are the clinicians going to take any notice and adopt a method? You know, what are their requirements to change their sort of traditional way of deciding what treatment to initiate? What would a marked change in a treatment need to demonstrate to persuade them to change what they're doing currently?
Yeah. Well, I guess, I mean, all of my research has been focused on radiotherapy treatment. And I guess some of the limitations that I talked about in terms of radiotherapy being planned on CT at the moment is largely because radiotherapy is delivered using linear accelerators that have CT imaging for planning. However, there are groups around the world and some clinics at the moment that have MRI linacs, so they are able to take MR imaging of patients and plan treatment using MRI instead. So this form of therapy where we are actually tailoring the treatment to the prostate based on the tumour location and characteristics is likely to happen anyway, just because of this is where technology is heading. And in terms of developing imaging biomarkers that can assess treatment response, it's a natural progression from what is happening in the industry at the moment.
Yeah, I guess we males would prefer not to have to fly to Melbourne. We'd like Auckland to get up to speed.
Yeah, I think there are a few areas where New Zealand lags a little bit behind. I think the economy is a little bit smaller, but I mean, with PET imaging in particular, Australia has been an earlier adopter of that technology. So PET imaging is used a lot for prostate cancer staging, whereas it's available here in New Zealand and here in Auckland, but I think it's very expensive and not frequently done, at least not as frequently as in Australia. There are MRI linacs in Australia. Here in New Zealand, I don't think there are any at the moment, but my collaborators at Auckland City Hospital say that they would like to have one within the next 5 years. So at least, yeah, the country is moving.
Well, that's good.
moving
that's good.
in that direction, but yeah, there's still a lot to do.
Thank you.
Thanks.
Thank you, Hayley. Looks like no more questions, but I have the last question. I'll have the last question. Yeah.
Sure.
Tell us about how was your first experience presenting on Zoom?
I think I prefer in-person presenting, to be honest. Yeah, I hope I explained everything in a way that people could understand. Sorry for my nerves. I think, especially with my PhD and first postdoc research, it's been a while since I've presented that, but yeah, it was nice to be able to outline that research, because there's a lot that still needs to be done. So yeah, I'm glad to be back at the ABI.